So bear with me. All right. I think we all know him. We're going to begin our afternoon session, and our first speaker is Dr. Rick Moss. He is the former chief of the Pediatric Pulmonary and Allergy Divisions at Stanford University, was the CF Center Director at Stanford from 1991 through 2009. Dr. Moss has a long list of professional accomplishments in the field of CF. His recent research has focused on allergic fungal lung disease and the treatment of chronic airway diseases of childhood. Please help me welcome Dr. Rick Moss. Thank you, Rick.
Which the advancer, this one? Okay. Thanks. So I have the unenviable task of going over everything about CF and doing it in less than an hour, so good luck to me on that one. One of our questions was, when was the CF gene discovered? And I think several people here did know that, and this is where the modern era of CF really begins. I got involved in CF as a resident back in the late 70s and then as a fellow. And I can tell you that through the 1980s, there was a long effort by many people to understand the genetic basis of CF. We knew that it was a autosomal recessive single gene disease, but didn't know much beyond that. And the foundation of modern molecular genetics was really established by what happened in CF through most of the 1980s. It took about 10 years to do this, but this was the culmination, and this particular issue of Science magazine had 3 very big articles which described the CF gene and talked about how they did it and predicted what the protein would look like, and that prediction has been borne out by direct evidence since then. The reason this is so important is because it really allowed people to start to understand how the disease occurred, and ultimately led to the development of drugs that Dennis Nielsen will tell you about that are directed directly at the problem in the protein produced by the faulty gene. So if we look at the survival statistics in CF, you're all familiar that things have generally gotten better and the trend has been continuously upward. There are still big differences. We had some discussion over lunch about why different centers, different regions, different countries might have different outcomes in their patient populations. It's a very difficult question to answer, but in general, there's been a very encouraging increase in life expectancy for CF. And most of that had to do with things that occurred in the 80s and 90s as we understood better about nutrition, and we started to deal with the issues that Jeff talked about with infection and its consequent inflammation. In the United States now, we can see that CF is still a pediatric disease in terms of the bulk of the patients. You can see that about 50% comes in the pediatric age group. And with a tail going out now, we have some patients in their 60s and 70s that we're following now. But this drop-off occurs because of the progression of the disease, of course. So let's start with just a little epidemiology. We already, again, one of the questions was about the number of patients. About 30,000 in the United States. That results from a number of 10 to 12 million carriers, people that have one CF gene that is not working properly, that's mutated, and one healthy one. Those are carriers, and all the parents here are carriers. You're healthy people, because if you have one copy of the gene, you make 50% normal protein, and that's enough to make you healthy. And that's very important for drug therapy, because that means if we can get a drug therapy that gets us to 50% function, we probably would have at least control, if not cure, the disease. And we're getting closer to that with some of the compounds that are being either on the market now or coming to the market soon. The majority of cases are diagnosed in infancy. In the United States, about 1,000 new cases each year are picked up. And this gives a rate of about 1 in 3,500 newborns. There is a significant difference in different ethnic populations, more common in Caucasians. Ireland does have the highest rate in the world in terms of frequency of CF, but you can find it in basically any population around the world, even in Africa and Asia, although the incidence is much lower. In the US, we have now recognized the big problem with our Hispanic population, which is large and growing, and a lot of work has been done. Our center has been particularly interested in this question because of the high number of Hispanic patients that we follow, but in general, an understanding of the kinds of mutations that cause CF and differences in different ethnic populations is important also. As you might expect, California is the most populous state, has the most patients, and generally the big centers are located in the states with high population. The protein, which is called CFTR, cystic fibrosis transmembrane conductance regulator, is on chromosome 7. As I mentioned, it's been known since the 50s that it's an autosomal recessive disease, which means that you need to get a copy of a mutated version of the gene from each parent to show the disease, and that's why only 1 in 4 pregnancies will result on average in a patient, and the others would be 2 carriers in a healthy person with 2 wild type. And about 1 in 30 people being carriers. The CF protein itself mainly functions as a channel for anions, chloride, but also bicarbonate, and probably some other small molecules also. And the effect of it is to fail to transport the chloride and also bicarbonate in and out of cells that line certain parts of the body. And that's what produces the effects in the different organs that manifest as CF. We're close to 2,000 mutations being identified in this single gene. So it's a pretty large gene and a fairly large protein. And the most common mutation that everyone here is familiar with, F508del, is present in about half the patients in the world. Both copies, homozygous, and another 40% or so, 1 copy. So about 90% of people with CF have at least 1 bad version that is resulting from this mutation. But amongst all these other mutations, they are associated with varying degrees of function, as well as what we call penetrance, that is their expression, and therefore severity in the disease that results. So how do we actually diagnose cystic fibrosis? This has actually been changing over time, and we still rely on a combination of clinical criteria and evidence of CFTR dysfunction. And we should make a distinction between newborn screening programs, which pick up people with potential cystic fibrosis, from those that are actually diagnosed. So to get a full diagnosis, generally speaking, you need to have at least 1 characteristic phenotypic or clinical feature, or a history of CF in a sibling, or a positive newborn screening test. But this is not sufficient to make the diagnosis. You then have to show CFTR dysfunction in addition. And the traditional way that this has been done is through the sweat test, the sweat chloride test. And this is not a trivial test. It's actually, for those of you that have had your kids tested, you know that it's a finicky test. And certain places don't do it as well as other places. You have to have technicians that have experience with it as well as the right equipment. And that's why we like to get 2 of these tests, confirm a positive test with a second one. But there now is the alternative of doing this genetically by identifying 2 disease-causing CFTR mutations. So this actually becomes quite a difficult issue because many people that may have one of these clinical criteria may or may not have an elevated sweat chloride and may have 2 changes in their CFTR gene, but is this disease causing? The third way we can do it is to look at direct function, and the way this is most usually done is to look at the transport of chloride in the respiratory tract, usually in the nose, through a test called the nasal potential difference measurement. Now, the identification of mutations in CFTR that actually cause disease is actually not trivial. There are changes in all genes that can be detected with modern techniques that may not necessarily compromise the function of the protein. So these are sometimes called polymorphisms or non-disease causing changes, variants. You'll hear all of these terms. And it's been quite a difficult story to try and actually identify which among those 1,900 variants or polymorphisms or mutations actually cause cystic fibrosis. And if any of you have not consulted CFTR2 and you know your child's genotype, you should do that because it gives very useful information. There's a portal for professionals, and there's a portal for patients and families also on this website. And they've worked through several hundred of these 1,900 mutations, the more common ones, to really see if they cause the disease. And the way that's done is actually very involved, because you have to link that up with clinical data as well as additional testing in the laboratory and other tests. But that's been useful. So putting these things together is the way one arrives at a CF diagnosis. So if you have a positive newborn screen infant, that infant needs to be assessed at the CF center, have a sweat test done, have other things done to look at their clinical presentation. And we actually are following a cohort of babies and young children now. Been doing this in California since 2007. We, as in other states, have identified a group of young children who have 2 variants in CFTR who we're not sure have CF yet, because the changes in the CFTR that have been discovered, we don't know for sure if they actually cause the disease. And as time goes by, some of these young children are developing CF and some are remaining healthy. So what that has done is to expand the world of CF beyond what it used to be. And that's a significant change. So the diagnostic tests for CF, we mentioned the sweat test, where we look at the sweat test level. The traditional cutoff of 60 milliequivalents per liter, this is the amount of chloride in the sweat that's collected on 2 separate occasions, is valid in term babies at least 48 hours of age. In preemies, it's more difficult. And in young infants, the actual level can be lower. So that creates more diagnostic uncertainty. Here in California, the way that we test initially in the screening test is to look in the blood that's collected when the heel stick is made in the nursery. And that little spot of blood is tested for a type of trypsin, which is a pancreatic enzyme that actually is increased in newborns because of damage to the pancreas in utero. So that is a screening test. That's not a diagnostic test. That results in a referral for the full diagnostic evaluation if it's elevated. And then I mentioned, of course, the genotyping, looking directly at the DNA to see what the changes are. So nowadays we see this has been picked up in all 50 states. I mentioned we started here in California in 2007. And that's resulted in a large number of diagnoses very early in life. As you see here, the largest number currently in 2013 is in the first month of life as a result of the universal newborn screening. And then a large number also occurring in early infancy, and then a big fall off, but we still see patients that are being diagnosed in later life. These are people that did not have screening done and present later with symptoms, and that's the traditional method of diagnosis. So there are still adults being diagnosed with CF, and some of them have had other diagnoses for years or decades, things like they've been called chronic bronchitis or bronchiectasis. Newborn screening really started to take off just in the last 10 to 15 years, starting at about 2003-04. Before that, there were pilot programs in just a few states. And in the last decade, there's been this tremendous uptake so that now all 50 states are using newborn screening to diagnose CF. And that's really that was not something that was accepted initially, because the idea was, well, does early diagnosis really change the outcome? And it took a long time to persuade people, including regulatory authorities and governments, that it was a useful thing to do, that it was cost effective to diagnose a baby with CF at 1 month, rather than wait a year or 5 years to make a diagnosis. But if you think about what everyone here knows, the agony that you went through getting to a diagnosis, that alone would be justification, and the avoidance of early hospitalization is a huge benefit also. Jeff went into some of the details about CF pathogenesis, so this basically just outlines it very briefly. We have this defective genetic material creating a protein that doesn't work properly. That has an effect on the way salt and water are secreted and absorbed, and the way mucus is secreted by mucus glands. That creates a situation where obstruction and abnormal mucus can lead to bacterial infection that triggers inflammation. There's also some evidence that inflammation can occur in the absence of infection because of damage to these cells lining the airway. They lack oxygen, they start to die, they release cytokines or chemicals that stimulate inflammation. So there's a number of reasons that inflammation occur, but no doubt infection, inflammation, and obstruction are the three things that are driving this lung disease. In the lungs, we know that 90% of the morbidity in CF and mortality is related to lung disease. So this is our biggest clinical problem and the biggest problem you struggle with as families. Early in childhood, the mutations affect the way the lungs work, and net result is this very damaged lung with airways that, as Jeff mentioned, lose their tone, they lose their function, they basically become pockets where pus can accumulate and fester. And it becomes very difficult to get rid of this problem once it's occurred. That's an ideal environment for microbes. One of the interesting things that we've learned in the pulmonary field in the last 10 years has been that all of us have a certain amount of foreign microbes in our lungs, just like our guts, our skin. That's called a microbiome. There is a healthy microbiome that exists in the lungs. And when you have a problem like CF, it distorts this microbiome greatly, and you get a very different pattern. And we're just learning now about what effect that might have on the onset and progression of the disease. We really don't know how to interpret this information yet, and I think this is going to be one of the major areas of research going forward. The progression of lung disease is heavily influenced by these microbes who we are able to culture because of their high number and the use of selective media in laboratories. And this does get me to a point here about some of the practical aspects of this. How do we detect this? Well, in young children, they don't cough up the mucus, so we need to do swabs of the throat to indirectly see what might be down in the lungs. And there have been some studies correlating what you get from a throat swab with what you get directly from a lung if you're able to go into the lung and put a little salt water in there and draw it out and culture it. And it turns out that the throat swab is a reasonably good predictor of what's going on in the lung. So that, for example, if you have Pseudomonas in the back of the throat, there's a high likelihood that you also have it in your airways, and therefore it would be a good idea to get rid of it, as you've heard about today. But we know that there's a number of other important microbial pathogens or harmful organisms that we can culture from our patients. We also know that people have recurrent exacerbations. This is another area where we really, I think, lack some important clues as to what's going on. People with CF can kind of go along and be on an even keel for a number of days, weeks, months, or even years, and then suddenly get sick. And why are they getting sick? Well, we know that in about 30 or 40% of these, there's a viral infection going on at the same time that's probably disrupting the balance that's occurred and causing an exacerbation, an illness episode. But that still leaves the majority of these episodes where we really don't understand exactly what's going on. If we look at the microbiome, we don't see many big changes going into an exacerbation, although in some cases we're now identifying organisms which we didn't even know were there or were minor that are really showing up as perhaps the triggers of these exacerbations. So that's another area where I think future research is going to be very helpful. And then we know that this problem can lead to a number of very, very serious complications, including pneumothorax, which is an air leak, like a tire that bursts inside the chest, bleeding, because these areas of damaged airways are adjacent to blood vessels. They can erode into these blood vessels, and then you get bleeding into the airways and coughing up of blood, and ultimately respiratory failure. So how do we follow this lung disease? Well, traditionally we've arbitrarily divided people into mild, moderate, and severe, healthy, moderate, mild, moderate, and severe. And this is usually done by measuring lung function in the clinic through the test, the spirometry test, which basically involves blowing out as hard as you can into a tube that measures the flow into and the volume of air that you're pushing out. And the amount that you can push out in that first second, that is the FEV1, the forced expiratory volume in that first second. That's been the benchmark that has been very important, not only for care of patients, but from a regulatory viewpoint, approval of new drugs. And this is important in CF because it's a relatively insensitive measurement. The FEV1 is the only test that the FDA has really accepted as a surrogate for outcome in CF. So if a drug company, whether it be Vertex or Genentech or anybody else, wants to get a drug on the market to treat people with CF, they need to show some change in the FEV1 suggesting a survival benefit. The problem with that is, as an insensitive measure, most children with CF these days don't have abnormal FEV1s. If it's over 80%, it's considered normal. And so there is really a difficulty in detecting a change. The higher your baseline level is, the harder it is to show an improvement, for example, with a new treatment. We do know that more frequent and severe exacerbations cause more damage, and a portion of people with exacerbations do not recover. About 25–30% don't get back to where they were at the start of the exacerbation. That's a very bad sign. So we try very hard to not have that happen, and the best way to do that is to recognize an exacerbation early and treat it aggressively. We also know that there's some certainly older patients with atypical CF that have very mild lung disease, and I'll come back to atypical CF in a moment. But as I mentioned before, most kids actually have, quote, normal lung function as measured by the FEV1. As a pediatrician and pediatric pulmonologist, I and many others in the field are very interested in getting better tests, more sensitive tests. And we do have those available, and we are using them in clinical trials and to some degree in patient care. But you have to recognize that the FDA has not yet recognized them as valid measures. So that's a problem that needs to be addressed, and I think over time it will be. Turning to other aspects of CF, you heard some about nutrition from Julie, but that's just one issue in a very complex set of problems in the GI tract. The nutritional issue results mainly from dysfunction of the exocrine pancreas. That's the part of the pancreas that makes digestive enzymes. That gets destroyed actually even before birth in most patients with CF. And that's why enzymes are needed from the time of diagnosis. Another very common problem is gastroesophageal reflux, or acid reflux, going back up into the esophagus. And that may play a role in the progression of lung disease, because if that acid gets into the lung, it can be very destructive. And so treatment of reflux is another important thing, not to mention just the symptoms being very uncomfortable. If you've ever had reflux, you know what I'm talking about there. We now know that CF involves the bowel itself. CFTR is expressed in the intestines and has a function there in terms of the absorption of nutrients. And also, when it's not working, there's inflammation in the bowel. That's another site where there's inflammation without infection in CF. The liver and the gallbladder are also involved, because CFTR also has a role to play in the liver and the gallbladder, in particular in the way the bile is secreted into the bowel. Bile is an element that helps digestion. And most people with CF have some involvement in the liver. Luckily, most of the time that's mild, doesn't create clinical problems, but when we do a blood test, like a liver function test, looking at blood enzyme levels, we can see this dysfunction. And malnutrition you certainly heard about. But there are also other affected systems. Jeff talked about the sinuses, and that's certainly something that's received a lot of attention. One of the problems with sinusitis and CF is people with chronic sinusitis get used to it. And so they don't complain about it as much as people with acute sinusitis. And unless one is really keyed in on this, and I think Jeff made this point, it's going to get missed and not treated. We started in the mid-90s to be very aggressive about sinusitis. We actually did, some of you may remember, we do operations and then put catheters into the sinuses and flush them out directly with antibiotics put through those catheters. Nowadays, people are a little bit less invasive, but they still do the surgery, and many patients are on a daily sinus flush routine, sometimes with an antibiotic added to that. The endocrine pancreas, the other part of the pancreas, is involved in sugar metabolism. So When that gets affected, then we get the problem of CF-related diabetes, which is a different kind of diabetes than the diabetes that people talk about in general. It's not the same as juvenile diabetes. It's not the same as adult onset diabetes. But it's a peculiar mixture of the two, and it needs specialized treatment. And even endocrinologists, they're very familiar and comfortable dealing with diabetes, not so much with CF diabetes. And some of the approaches that they might take are actually perhaps not so helpful. For example, restricting caloric intake, which is a strategy one would use in non-CF diabetes, may not be the best thing for a patient with CF. And then, of course, the musculoskeletal system is also involved. So folks with CF have weaker bones, and they're prone to develop osteoporosis if it's not treated, and that can lead to fractures. So that's an issue which, again, cannot be neglected if it's not looked for. Because of the improved survival, there really has been a change in the proportion of kids and adults with cystic fibrosis. And this just shows the trend of the number of adults over the last 20 years or so, 30 years, and you can see that it's now about 50-50. In fact, 50% of the population now are adults. The median survival around 41. And still a large number of adults that are undiagnosed. Again, these were people that were not picked up because screening didn't exist when they were born in early childhood. And many of these folks do see physicians, they do get sick, but they're not being looked at as potentially having cystic fibrosis. I just would also mention, in terms of this, of course, this has driven the creation of adult CF centers. So I think it was around 1999 or so the foundation actually mandated the creation of adult centers, and that put a lot of stress on various medical centers because oftentimes the staff, including physicians as well as others in the caregiving team, were not available or not interested. And so it's been a long haul to get adult programs set up and up to the level of expertise, but many places now do have excellent adult centers. I mentioned atypical CF briefly before. In the classic case of CF, as we have talked about, we have all these manifestations, the lung disease, but also pancreatic insufficiency, high sweat chlorides, males with infertility due to blockage of the sperm duct, sinus disease. If there are milder mutations, the disease may well present differently. And while you still may see sinus and lung problems, most of these people with milder mutations don't have pancreatic insufficiency. They may have attacks of acute pancreatitis, which has been recognized now by the GI community as an important sign of potential CF. But they may not require enzyme therapy because they're making enough enzymes to digest food, and their sweat chlorides tend to be lower than in the classic CF. The males are still infertile because the vas deferens, the sperm duct, is probably the most sensitive tissue in the body to CFTR dysfunction. Now, I heard a lot about infection earlier in the day, and I won't belabor this, but there's a number of bacteria that are tracked by CF centers, and this requires two things which are not readily apparent. One is you've got to do it frequently because of changes that occur. And the second is you actually have to have a laboratory that is looking for these, and these organisms don't just grow on run-of-the-mill culture media. You have to have specific media that are optimized to grow these organisms. So unfortunately, some people with CF now, due to restrictions in their health coverage, may have cultures sent to a central laboratory that does not focus in on CF and may not do these kinds of selective media. So their rates of recovery are going to be lower than a CF center that has a micro lab that is looking specifically for these organisms. And another level of difficulty results from our sort of recent knowledge that if you do non-culture techniques, looking for the bacterial DNA, you find a lot more than you get from these culture results. And we're still, as I mentioned before, just learning how to interpret that information. But looking at this, we see that in different age groups, we have different prevalences of these different organisms. And Pseudomonas in the blue is present early in life in 20 to 30% of patients. And the incidence continues to go up through later childhood and early adult years. It has gone down somewhat with the spread of the eradication philosophy that Jeff talked about. So that's a good thing. But there are other bugs to worry about also, and some of these emergent bugs have become more common, including, in particular, a form of staph that is resistant to one of the antibiotics that's used to test for it, called methicillin. That's MRSA. You've probably heard of MRSA. This is an organism that's present both in the community as well as in the hospital and clinic environment. And that's become more of a problem in CF. That's found in somewhat younger patients than Pseudomonas, but still quite prevalent. Then we have these other, some of these other organisms also. But when we find any of these, we really are faced with the question of what to do about it and how aggressive to be about trying to get rid of each of these organisms. And that is not something that has achieved universal agreement about how aggressive to be about getting rid of all of these different organisms. Certainly for Pseudomonas and Burkholderia, Cepacia, as you might have heard, these are organisms that we try very hard to get rid of. Pseudomonas is still, I think, the most significant pathogen in cystic fibrosis. And we know that because the infection is associated with deterioration. The rates of decline of lung function accelerate after one acquires the mucoid form of Pseudomonas. And it can be found very early in life, even though it becomes more and more common as people get older. There are some risk factors that have been identified, including it being more common in females, the F508 mutation, and coexistent Staph aureus infection. The pulmonary environment, and Jeff mentioned this in his talk about how these bacteria adapt over time. They have mutations that allow them to adapt and persist in the lung. And we also know now that there are different, actually one person can harbor several different strains of the same organism. And these different strains can exchange genetic material. So the net result of this is that the organism is often able to survive within these mucus plugs in the airways. And this growth as a biofilm means that the mucoid material that you saw earlier, which sort of coats the bacteria, is a barrier to antibiotics as well as to the immune system and makes it harder to eradicate these organisms. That's why it's so important to try to avoid the onset of mucoid Pseudomonas infection. The repeated use of antibiotics does contribute to the increase in mutations, and that's one of the downsides of continuous exposure to antibiotics. So that's a complicated story, and I appreciate Jeff's argument, but there are other aspects to this situation that also need to be taken into consideration. So preventive antibiotic therapy, maintenance therapy, and early aggressive therapy with a focus on Pseudomonas have really contributed to some of the improvement we've seen in CF. Lowering the rates of Pseudomonas, I think, has played a part in the improved quality of life and also survival of patients. I mentioned MRSA. We now see about a quarter of all the Staph aureus isolates in CF in the US being resistant to methicillin. That's not necessarily a treatment problem because these bugs are still quite sensitive to a number of other antibiotics that are easily available and used. And up to a third of the patients may also have some of these other so-called gram-negative organisms like Stenotrophomonas or Achromobacter. And Burkholderia cepacia, this was a problem that became apparent in the early 90s, the so-called cepacia syndrome, very aggressive, virulent bug. We've learned a lot about this particular organism in the last 25, 30 years. Nowadays, about 3% of adult patients have it. Luckily, it's pretty rare west of the Sierra. So the centers along the coast, both in northern and southern California, don't see much of this, and that's good. But in certain pockets of the country, it's still a big problem. And we now know that there's a large number of different species that go under this, that are in this family, Burkholderia. And not all of them are bad players. Some seem to be much less aggressive than others. So if your child has grown this, it's very important to get into a discussion with a physician about the exact form of Burkholderia that's present. One thing that is very, very worrisome in recent years has been the increase in a form of mycobacterium called non-tuberculous mycobacteria. TB is in a family called mycobacteria. So this is not TB, but these are relatives of TB. These are bugs that are like TB, and they have a predilection for people with damaged lungs. So we're seeing this increasingly in our patients with CF. In our younger patients, a species called abscessus, and in the older patients, a species called avium complex. These are bugs that are very hard to treat, and particularly abscessus is extremely difficult to get rid of and can be a devastating infection. So this is a problem that has been recognized and has contributed, I think, significantly to our degree of rigor in at least the infection control we would like to have present in our clinics and in the hospital. I mentioned some of the complications, the more severe ones, pneumothorax and large amounts of bleeding. It's not uncommon to see small amounts of bleeding because of the inflammation eroding small blood vessels in the lung. But seeing a lot is, of course, a very worrisome thing, very scary thing. Occasionally can be life-threatening. There are ways to treat that, but they involve getting involved early with the hospital. There's another complication that about 10% of our patients have, which is the development of an allergic reaction to a fungus that can grow in the lung called aspergillus. And this fungal allergy causes a kind of a problem that has aspects of asthma and aspects of infection with tightness and wheezing and worsening of lung disease. This is actually a difficult condition to diagnose, but it is treatable, and it's important to look for it, and most centers now screen for this. Talked about the sinuses before a little bit. Polyps actually are just the way the nose responds to infection and inflammation by sort of proliferating the tissue, and we'd like to be able to treat sinusitis without seeing nasal polyps, but if they're present, they can be fairly easily removed. The problem is they'll grow back if the sinusitis is not controlled. The lung disease can put a stress on the heart, and the part of the heart that's stressed is the right side of the heart, because that's the part that pumps blood into the lungs. The left part of the heart pumps blood to the body. The left part of the heart is very muscular, but the right part of the heart is not muscular, and therefore it can be stressed very easily. This is something that I used to see a lot, I'm sure Dennis did too, in sort of the older days. But as we've gotten better at treating CF, we see less and less of this, thankfully, because this is a very bad complication. But it's very important to recognize that if the doctor is prescribing oxygen because of low oxygen levels, that's really the best treatment to avoid this disease, this complication. And the use of oxygen has been very important in reducing the incidence of cor pulmonale, or right heart failure. Lung transplants these days, of course, are on the table for anyone with very bad lung disease, and the definition of that can be complex or can be simple. The simple version is if the FEV1 is repeatedly below 30% predicted, that person's probably a candidate for listing for lung transplant. But as you know, lung transplant centers go through a very complicated and full evaluation of many different aspects before offering lung transplant as a possibility, because it's not a panacea, it's a treatment, but not an event-free solution to CF. So I'm just going to turn to the basic pillars of treatment, and I view this as really a triad that's based upon airway clearance. As you heard, get rid of that mucus, antimicrobials to treat that infection, and nutritional support, which you've also heard about. So airway clearance really is the first pillar, and besides the actual mechanical clearance that involves exercise, various forms of physiotherapy, there's also the issue of appropriate vaccination. I wish I didn't have to say this, but it's an issue. People don't like to get some people don't like to get vaccines for various reasons. In CF, we focus especially on things like influenza as well as pneumonia. We have vaccines for these things. But besides mechanical clearance, there's also the use of agents that help you get the mucus out. And this can be done by hypertonic saline, which is a mucus thinner, but also stimulates cough and stimulates possibly the ability to cough out the mucus, as well as agents that directly help to lessen the thickness and liquefy secretions such as pulmozyme. And there probably are other drugs that can be used for this also, like N-acetylcysteine. So this is all, how do we actually employ this? It's really empirical, by which I mean a one-to-one discussion with each family. What works for you? And Kristen's going to get up later and go into more detail about the aspects of respiratory care. It's not one size fits all. It's not one shoe fits all. These are very individualized approaches that have to be discussed. That has to do with age, adherence, willingness to spend time. All these things come into play. Cost. All these things are important. But the idea is to optimize the clearance on a case-by-case basis. So often, it's really trial and error. So you're going through one thing. If that's working well, you stick with it. If it doesn't, you try something else. Antibiotics are the second pillar of treatment, and you've heard about this already. Maintenance therapy is really reserved for people that already have a chronic infection. This is what we're trying to avoid, but the truth of the matter is that the current state of the art is that many patients still wind up getting chronically infected. And so in those patients, we have regimens to suppress, to keep the bacterial count down. And we do this usually with a rotating use of inhaled antibiotics. Obviously, exacerbations need to be treated. I mentioned that the earlier and the more aggressively you treat them, the better the outcome's going to be. And this usually involves hospitalization with IVs, and usually involves a 10 or 14-day stay in the hospital or treatment at home. One antibiotic, azithromycin, has been added to the standard of care for most patients. Although it's an antibiotic, it has anti-inflammatory effects, and we think that its main effect may be as an anti-inflammatory agent. So these therapies are usually guided by our cultures and sensitivities. That's where the lab comes in. And usually acute exacerbations are treated. We do distinguish between mild, moderate, and severe exacerbations. Many mild exacerbations can be treated at home by addition of more aggressive airway clearance and augmentation or initiation of antibiotics. And the maintenance therapy, primarily for Pseudomonas, chronic Pseudomonas infection, inhaled antibiotics, either on an alternate month basis or continuously using a rotation, are what many people are doing. And that's just listed there. These things do help patients. They improve lung function on average about 10% and reduce hospitalizations by about 25%. And this is for people already with chronic infection. In addition, we know that eradication therapy works in about 80% of cases. So it's not 100%, but in most cases it's successful. And then surveillance through regular clinic visits until the next time it occurs, which may be months or years. And azithromycin as a chronic therapy, mostly azithromycin is used, it's that Z-Pak, that 5-day treatment for an ear infection or bronchitis. In CF, we use it very differently. It's a chronic medication. And there may be downsides to that over time, that it may lose its effectiveness, so it's something that needs to be monitored. There are other agents that can be used for inflammation, and the most important of which are non-steroidal anti-inflammatory drugs. This is a class of things that are not steroids, like ibuprofen. In younger patients, high-dose ibuprofen has been shown to be beneficial. And this has been shown both in clinical trials and also in registry data, epidemiologic data, but seems most helpful in younger patients with well-preserved lung function. There are very rare events of bleeding because ibuprofen can be associated with bleeding, and also kidney effects. But these are quite rare and shouldn't deter the use of anti-inflammatory agents. This is one area of treatment of CF that needs better drugs. We need drugs that are more effective and potentially less toxic. Steroids work very, very well in CF. The first controlled clinical trial in cystic fibrosis that showed an effect on the disease was with corticosteroids in the 1980s. The problem, as you probably know, is that steroids have terrible side effects. So although we would have liked to have been able to use prednisone or other drugs like it long-term to treat CF, it's just too high a price to pay. Creates diabetes, weakens bones, has a bunch of other effects, short stature. All these things have precluded the use of long-term steroids, but they can be helpful in the short term. And we do have inhaled steroids that may be beneficial in CF. This is somewhat controversial, but there's at least some good evidence that inhaled steroids may slow the progression of CF lung disease. But we do worry about some of these side effects, and these have to be monitored carefully if steroids are used in any form. And as I mentioned, the optimal anti-inflammatory regime has not yet been identified, so there are new anti-inflammatory agents that are being tested now that hopefully will be better than what we've had before. I think that's an area that is likely to be successful ultimately. In the GI tract, the liver disease can result in cirrhosis, which is basically a scarring of the liver. And we try and avoid that through use of a bile salt called ursodeoxycholate. And this is basically something that helps bile excretion, but the effectiveness is really hard to demonstrate, and it's not clear that it can prevent this complication from occurring. The good news is that serious liver disease really only affects a small percent of CF patients, 1 or 2%, where the liver actually fails. The exocrine pancreas, we've really talked about. 90% of patients need enzymes, and we also need to give supplemental fat-soluble vitamins for this problem. What about diabetes? This is really the most frequent GI complication after pancreatic insufficiency. It's age-related, and over time, the treating community has become more aggressive about looking for diabetes early, looking for glucose intolerance, which is a precursor to diabetes. Clearly, if you have diabetes, you need treatment. Right now, it's not entirely clear how early one would intervene for impaired glucose tolerance, that is pre-diabetic condition. But that's something that we're grappling with now, and studies are ongoing in that regard. As I mentioned before, CF diabetes is unique, and therefore you can't necessarily assume that folks who are familiar with diabetes in other situations are going to be adequately informed for CF-related diabetes. In fact, we have to work very closely with our own endocrinologists to come up with agreed-upon protocols for treatment of our patients. The reflux disease is pretty common, especially later in life. Probably all that coughing loosens the muscle that keeps the acid from going back up the esophagus over time. Luckily, actual peptic ulcers are rare in cystic fibrosis. But we do get inflammation in the bowel, as I mentioned before, and that can cause abdominal pain as well as impaired nutrient absorption. Some folks with CF get obstruction in their small bowel, usually at the very end of the small bowel. That's called DIOS, distal intestinal obstruction syndrome. You may have heard that term. And some people have recurrent episodes of this. It's very distressing. It can be a surgical emergency in its worst form. Luckily, in most cases, this can be treated with a combination of things including polyethylene glycol solutions like Miralax, which can be taken by mouth or nasogastric tube, and sometimes one needs to use an enema to disimpact from below. One thing that people are a little less aware of is the fact that inflammatory bowel disease, I mentioned inflammation in the gut of patients with CF, this results in an actual inflammatory bowel disease that is much more common in CF than in folks without CF. So Crohn's disease is 17 times more common than the general population. The other thing that we've become more aware of as people with CF live longer is that they've become more vulnerable to GI cancer. Julie went over enzyme supplementation. These are just some of the general recommendations. I'll just mention that often it helps to have an acid suppressor added to help the efficiency of these enzymes, even though they're enteric-coated beads. If you can reduce the stomach acidity, you can probably get better effect in many people. So if you're having trouble with your enzyme therapy, addition of acid suppressor, whether it's a so-called H2 blocker like Zantac or a PPI like Prilosec, can be helpful. With more adults with CF, we're now really aware of the fact that they're at risk for GI cancer. So one of the things that adults who care for CF patients need to do is pay attention to GI symptoms and screen for cancer, which usually can occur in the pancreas or in the small bowel or in the colon. So all of these things need to be screened for in adults with CF. Not so much a problem in kids, of course, but over time this does emerge as an issue. I mentioned briefly the bone disease. About 14% of patients will develop bone disease. This is a weakness of the density of the bone. It can be picked up by a bone density test, very easy test to do, DEXA scan. And if it's really bad, you can get pathologic fractures, which can result in a lot of pain, compromised lung care. Imagine if you have a collapsed vertebrae in your spine. It's going to create a problem for airway clearance, amongst other things. So this is actually quite common in older patients, and it's something that, again, we can, if we are screening for it and looking for it, we can treat it early, we can usually prevent the real problems. Fertility is another area that's a problem. I know the series has had folks talk about fertility in the Discovery series that CFRI sponsors. As I mentioned, almost all men are infertile, which these days does not preclude being a dad through use of technology. And in women, pregnancy does occur. And actually, studies in more recent years have shown that unless you have severe CF, you're likely to be able to have a normal, healthy child and not have your CF the worse for it. And finally, I should definitely mention that we create some problems of our own by treating CF, so-called iatrogenic or treatment-related diseases or problems. One of the downsides of using a lot of antibiotics is that a certain percent of people will become allergic, and various allergic reactions can, in some cases, preclude the use of an entire class of antibiotics that create a serious reaction. In addition, some of the drugs that we use have their own toxicities. The most important is the aminoglycosides. Tobramycin is one, amikacin is another. This class of antibiotic, if the kidney is exposed to it, it will create kidney damage. It can also damage the inner ear. So again, as people get older with CF, you have to be aware of this and be screening for the occurrence of renal damage or hearing or balance changes due to inner ear toxicity. Nutrition is the third pillar. And Julie talked about this. There are ways to classify by body mass index that we use. And we try and go through a very extensive process of working with each child and family to optimize their nutritional status. And that was really the subject of Julie's talk, so I won't belabor that, except to say that I think the nutritionist is a key person in the care team, and I think all of you know that from your visits to the center. Psychosocial considerations are really important in CF. The main problems that we see are depression, which is measurable, and in general, 15 or 20% of folks with CF have clinical depression. Anxiety is even more frequent and common. Adherence, generally people speak about a ballpark adherence rate of about 50%. It may be lower than that for certain things, higher than that for other things, but that does influence what the outcome is, obviously. And the impact on the family, friends, and caregivers can't be underestimated. Late-stage lung disease is obviously its own issue as a psychosocial problem, especially if someone is facing shortened life and is looking at a lung transplant. And one of the things that the transplant teams do with great care is to go through the psychosocial situation of that patient and the family or caregiver to determine that they can get through. It's not just an operation, it's really a whole change of life that has to be dealt with. And other late-stage issues have to do with preparing for the worst case, which we all have to do anyway. People with CF have to do it a little bit earlier. So things like advanced directives for end-of-life care plans, living wills, power of attorney, these are all things that families need to consider. And it's a real tragedy when someone winds up in an ICU in a situation that nobody wanted because they didn't consider some of these issues beforehand. I showed this because of the fact that the registry does monitor a number of complications. This is from the most recent report. And if you just focus on sort of this gold bar, this is diabetes, and depression is in red. And you can see that there's an age-related increase in reported depression. And these are registry data. These are data that are sent in by the center, whoever at the center is collecting the data from the encounters. They're not from actual surveys with the best instruments we have to really diagnose depression. So they're almost certainly underestimates. And you can see that especially starting in the teen years, it really becomes a major issue as patients get older. One of the most important studies in this area was published relatively recently, and I just wanted to highlight that. This is a study that was done in over 6,000 patients and 4,000 parents of patients in 9 different countries using validated, accurate measures for depression and anxiety. And what they found in the study was that 10% of adolescents, 19% of adults, 37% of mothers, and 31% of fathers had symptoms of depression. Anxiety in 22% of adolescents, 32% of adults, 48% of the mothers, and 36% of the fathers. Well, what's the general background? This is 2 to 3 times that in the general population. So these are definitely very important problems to address. So one of the things that CFRI has done to address this is their Partners in Living initiative, and there's material on this in the back, which is a holistic approach to living with CF, and was really driven by the fact that the system is very poor at providing mental health professional support for these problems. Oftentimes there's insurance problems, there's access problems, there's lack of knowledge of who to refer to, and these folks are not integral parts of CF care teams. Yet, you've seen, this is a very, very big issue in this disease. So what are the components of the quality of life program? Well, the first thing is individual counseling with a mental health professional. And this is one-on-one counseling, and it can be done either in person or through technology remotely. And one of the most important things about this program as we designed it was that it was crucial to have no one turned away. So financial ability is off the table. A sliding scale is used, and if someone can't pay, then the cost is picked up by CFRI through the grant that's funding this program. Importantly, we've recently expanded this to nationwide service, and people from all over the country have responded, and it's been very gratifying to see that. In addition, there's a monthly caregiver support group with a professional facilitator that also is available for caregivers, and this support group situation is really helpful in dealing with the high degree of issues. I showed data on 2, depression and anxiety, in the parents of kids with CF. So having that community is really an important resource. In addition, the program also has recently initiated a mindfulness-based stress reduction online class. MBSR is a very widely used and popular program now to help deal with stress. And it's been very successful, and this just recently got initiated, so be interesting to see what the feedback is. We're going to be getting some data on that soon. And then finally, importantly, educational conferences like today, both coming here and also having it available online for people to look at later. So let me just wrap up with some care strategies. This is basically the routine that the CFF recommends. Many places do more aggressive approaches, including our center. But this is sort of the minimal standard that is expected, where visits are done quarterly, lung function is done at least twice a year, and certain screening tests, for example, allergic aspergillosis or diabetes or vitamin deficiencies, are looked for annually. In addition, the bone scans, looking at other aspects of potential complications of CF, picking up things early. It really depends on an ongoing communication between the caregivers and the centers. We do rely on the pediatricians and the family practitioners to work with people at the center in identifying what problems might require a consultation or referral to the center, what can be handled in the primary caregiver's office. But this cooperative care, we think, offers the best probability of treating problems early and preventing worse outcomes. I want to close just by acknowledging how hard life is for families with CF. This has been looked at, and this is just one study that illustrates this treatment burden. It's a function of several factors. It's how we prescribe things. You're always wondering, things are added and never taken away. Maybe that'll change in the future, but we haven't gotten to that point yet. And the treatment burden really starts to hit home heavily in late childhood when some of these problems start to become more apparent. And in general, it's independent of disease severity. So in the average, in this particular paper, the average person with CF was doing 7 different daily things in terms of types of therapy: oral therapy, and this is the time that was involved, airway clearance, exercise, nebulization therapy, almost 2 hours a day. And this is for just the average patient. Obviously, if you're sicker, you're going to do more. If you're healthier, well, maybe you can do more exercise. And just to end with lung transplants, there has been an increase. We really started doing this in the late 80s. But over the last 10 years or so, it's really plateaued out. And that plateau is a function of the limited number of donors that are available. What has changed has been an allocation system which is friendlier to CF, so that as someone with CF gets sicker, they can get moved up in the queue, and waiting times are less now than they used to be, and that's a good thing because that improves overall survival. So let me just close with the general schema. CF care has grown up around treatment of secondary problems: pathophysiology, obstruction, inflammation, infection, and treatment of the bronchiectasis. So hypertonic saline is trying to improve the clearance, eucalyptics trying to reduce the obstruction, bronchodilators also to reduce the obstruction by opening the airways, anti-infectives to deal with the infection, anti-inflammatories, and when all else fails, referral for lung transplant. Where we've moved to through research has been investigation of gene therapy, protein therapy, and ion transport therapy. And as you all know, and I think Dennis will go into some detail about this, the real area of success to date has been our ability to start to impact the function of CFTR protein directly. Ivacaftor was revolutionary in being able to push that CFTR function up towards that 50% magic number. And so people who are taking ivacaftor now for gating mutations are by and large in control of their disease. We hope that we can do the same with lumacaftor in combination with ivacaftor. My view is that's a first-generation attempt. The others will have to follow, but it is pointing the way to how we're going to do this. And ultimately, I do think we're going to be able to do correction at the gene level, but we're still a ways off from that. And I also think fairly soon we'll probably be able to see some really effective therapies that bypass the dysfunction of the protein through stimulation of other alternative ways to handle salt and water transport. This is the last slide. These are the types of mutations. I encourage everyone in the room to know what particular mutations are present in your child because treatment is becoming specific. That's already started with the use of ivacaftor in this group here. The combination therapy is going to be aimed at this group, which comprises 50% of patients. And ultimately, we will get to the point where we can treat each of these with very specific therapy. So I'll stop there and take any questions. Thank you.
I have 2 questions and 1 comment. The first question is if we have any recommendations for screening for GI cancers, what would those screening tests be and at what age? The second question is about growth hormone. So my son, he did get growth hormone, and his BMI went from 5th percentile to nearly 50th. His height went from 25th percentile to 95th percentile, his genetic potential. And his weight also increased, and so we were able to obviate the need for a PEG tube. And to us as a family, that treatment burden was really reduced, not having to get a G-tube and being able to use growth hormone. So I'm wondering where we are on that. And then my comment is about the use of the pediatrician for the CF patient. And so I am a pediatrician, and I would just warn patients that most pediatricians, they have very little knowledge about CF. The parents will soon know more about CF than their pediatrician, and pediatricians have 0 to 1 patient that they follow for CF. And so really any respiratory question, any gastrointestinal issue should be addressed, I think, with the CF team, and they should go to their pediatrician for their vaccines and injuries and things like that, but not use them for questions about CF.
Yeah, so let me respond to the comment first. I agree with you, and I think that by and large that is my experience of how it works in the real world, and most pediatricians are perfectly willing to hand all the CF-related issues to the center physician or team. Sometimes an issue arises as to whether this is a CF-related problem or not. So that can be where the interface is. But you know, the way I've seen the real world is that pediatricians are generally more knowledgeable about CF than their adult counterparts, and this is an even more of a problem for the older patients. And the problem there is that some of these physicians who take care of adults with CF think they know more than they do, and that really creates problems for adult patients. But by and large, I think the pediatrician center relationship, my experience has been that it's good and that almost all pediatricians work very well together with the CF team. They really are responsible for the immunizations, for the ear infections, the throat infections, kind of the non-CF things that occur. Oftentimes people will call in and get the triage will be through our nurse, who, if it sounds like a general pediatric problem, they'll say, well, check it out with your pediatrician. Now, you had two questions. The first was about the GI cancer. I don't know if there are any, to my knowledge, there's no guidelines from the foundation on this because it's something that's emerged relatively recently, but most adult physicians will start to test for adult GI cancer when people are in their 40s or 50s, and in CF that should be moved up by a decade or so. And the screening tests, they range from things like occult blood in the stool to the use of endoscopy on a schedule. So I think it's the same thing that was done for the general population, but it would be started significantly earlier in the CF, should be started significantly earlier in the CF population. Your second question was about growth hormone, and yes, there are studies that do show a positive effect for, with treatment of growth hormone. Oftentimes the problem, there are a couple problems with growth hormone. One is the insurance problem, because it's off-label, and so there may be denial. Growth hormone is an expensive drug. And there are some potential side effects of growth hormone that, for example, it can perhaps unmask diabetes earlier. So growth hormone is not widely used in CF, but certainly cases like as the one you mentioned do show that it's effective. There have been studies showing it does have that effect. So it is a potential drug for CF.
Excuse me. I had a question regarding bone disease. That was new to me.
Mm-hmm.
And you had a graph up of a percentage was for in children. At what age would you recommend to get a bone scan to start getting tested for bone density?
Yeah, we generally start the DEXA screening at around the time of puberty, 10 or 12, and then repeat it every few years. And of course, if we do see osteopenia, which is kind of a precursor to osteoporosis, weakening, that would lead to a change in treatment that might involve extra calcium or there are some other medications that can help bone strength and more frequent monitoring. Yep.
Okay, so I have two kids with CF, and they both do the ibuprofen therapy. Mm-hmm. And I remember them going in for a lab test to see if the ibuprofen was effective.
Yes.
Can you tell me the name of that lab test and how often that should be done?
The lab test is a little troublesome because it involves several blood draws.
Yes.
Remember that?
Yes.
Yeah, what they're looking at is the peak level of the ibuprofen in the blood. And the reason for that is that the people that developed this therapy determined that you need to have a certain level to get that anti-inflammatory effect.
Okay.
So you want to be in a certain zone, so you want to hit that zone. And then in terms of repeating it, the general approach has been when the body weight changes by 25% or more, then you would need to redo that test because of change in size and metabolism.
And does it have a name? The name of the lab test?
Does the lab test have a name? Ibuprofen levels.
Okay. And then
but you need to get several of them, kind of like a glucose tolerance test. You need several blood draws.
Yes.
Yeah.
Well, and then I was interested to see that adults don't normally do ibuprofen therapy, and my son is almost 18. Mm-hmm. So would we just maybe repeat the test to see? And when the test shows that it's not being beneficial, you stop it.
You know, I hate to generalize to an individual. Your son may benefit from staying on it, but that's something that you need to discuss with the physician. This is just based on the results of the clinical trial that was done, which seemed to show that older patients did not have as good a response as the younger patients.
Thank you.
Yeah. Uh-oh.
No. This is a question about the mycobacterial infections. They're increasing. Is there any evidence that are those things that can be like the first infection, or do they typically come later on in the disease?
They would come later on. I haven't seen, Dennis may correct me, but I haven't seen cases where mycobacterial infection preceded the more common bacterial infections. Would you agree, Dennis? Have you seen?
I haven't seen it precede bacterial infections, but I've seen it in early patients, and it's always hard to know whether it's really...
Yeah, in general, it's a later, although we do have younger kids that have picked up abscessus. It's important to note that there's a distinction made between finding the bug and determining if they actually have disease due to that bug. There are criteria for non-CF patients that distinguish those two situations. That's been somewhat sloppily, or it's messy to apply that to CF, because it's like seeing nodules on an X-ray. Well, CF has nodules on the X-ray, so this can be difficult to determine. Generally, if the patient's deteriorating and not responding to sort of other therapy, that's when we would jump in with specific antibiotics directed for the non-tuberculous mycobacterium. But it's a very difficult business because these are tough bugs. I think that's it, so. Oh, I'm sorry.
One more.
Almost got away.
I just have a question about the ABPA.
Yeah.
You say is treatable and curable. What is the standard of care for that? And if you can elaborate a little bit more on that, please.
Yeah. It's complicated. ABPA is basically an allergic response to an infection. So you could treat the allergy, or you could treat the infection, or you could treat both. For the allergy, steroids are the mainstay. Steroids can be given in a number of different ways, but generally you need to use a pretty substantial dose and course of steroids. And then you can also treat the fungus by using an antifungal agent. And then some patients are also treated for the allergy with a monoclonal antibody called omalizumab, or anti-IgE, which is for severe allergies. So there's a variety of different treatments for that. But it's a chronic problem that comes and goes, so it's very difficult to get rid of it once and for all. So it's yet another one of those situations where you identify a problem, you treat it, and you monitor. So in CF, monitoring is the name of the game, and early intervention is a consequence of good monitoring. Thanks a lot.